The course is a unique, flagship, wholly online program delivering up-to-date knowledge and evidence-based patient-oriented experience in the principles and practice in pediatric nephrology. It is structured as 3 modules, 32 credit hours each. Each module will be delivered over a 16-week period. The admission is open for all physicians who have worked or currently managing with children with various kinds of kidney disease. The fellowship program is delivered by pediatric nephrology experts from various national and international programs to enhance the exposure of the candidates to different clinical experiences and clinical practices. The education is delivered in the form of online lectures, case-based discussions, critical appraisal of scientific papers, and problem-solving exercises. Clinical scenarios and real-life practical experience are discussed online by experts in the field. Moreover, virtual workshops and webinars will be conducted synchronously. All scientific materials will be released in a smart platform at the beginning of each week, Monday, 8 a.m. GMT. Fellows have the freedom to navigate the educational contents, complete their tasks throughout the whole week, and turn in assignments by each Sunday midnight, 12 a.m. GMT. All fellows' activities and assignments are monitored in the smart platform. Weekly qualitative assessment and evaluation will be performed based on each fellow engagement and activity in the program. Advisory Board. Upon completion of the program, the fellows will be able to be an expert in the PEDNEF field, graduate to a trainer-mentor level, and join the tutoring panel in the incoming programs, receive American Association of Continuing Medical Education Fellowship Graduation Certificate. The course is a unique, flagship, wholly online program delivering up-to-date.
Hello, everyone. Very nice seeing all of you today. We have very interesting webinar today and a very special guest speaker. We have our second World Kidney Academy Pediatric Nephrology Fellowship webinar. Last month, we have a very nice webinar, and this was focused on steroid unresponsive nephrotic syndrome. Today, we have another webinar on pediatric renal replacement therapy. We have great panelists, Dr. Ali Ashghar from Pakistan, Dr. Khalid ElHassan from Saudi Arabia. We have our guest speaker, Professor Rukshana Shroff. We have Dr. Sidharth Kumar from India, Dr. Hanan AbdelAziz from Egypt. So as you see, we have diversity and very good panelists from all over the world. I cannot introduce Dr. Rukshana because her long CV, so I will let Professor Ali and Dr. Sidharth to introduce her. She is a professor of nephrology at Great Ormond Street Hospital in London. Here is our short agenda today. I'm going to give some introduction about our pediatric fellowship program. Then Dr. Rasha Samir is going to give some samples of the question that you will have during our fellowship program. Then Professor Rukshana is going to give the main speech. Then Dr. Khalid and Dr. Sidharth are going to handle the discussion and the questions and the answer with Professor Rukshana. Then Dr. Hanan AbdelAziz will present a brief case of a child with complication secondary to chronic kidney disease. Then Dr. Ali is going to give us the closing remarks. Our pediatric nephrology fellowship program has a great board advisors from all over the world. Professor Ali Ashghar from Pakistan, Professor Elena from Netherlands, Professor Hanan AbdelAziz from Egypt, Professor Jamil AbdelAziz Qari from King AbdelAziz University, Professor Khalid ElHassan from King Saud University, Professor Niveen Soliman from Cairo University, Professor Rasha Samir from Mansoura University, Professor Rukshana from London, UK, Professor Rabish Reena from Ohio, USA, Dr. Sidharth Kumar from India, Dr. Chigan from Cape Town, South Africa, and Dr. Vandrea from Brazil. Why did we choose the pediatric nephrology fellowship to have 1 year online fellowship program? Because our kids are very special to us, and in many circumstances they have very difficult, challenging cases, and sometimes they have devastating consequences if they are not treated properly and precisely. Also, there is a huge management gap in treatment of our patients with kidney diseases. And in several cases, we don't have consistency or consensus in their management. We really need expertise in this field, especially in the developing countries. Our fellowship program is not one-way education. It's a dialogue rather than monologue. It's not based on just lectures or webinar, but also an interactive clinical-based discussion and MCQs, evaluation and assessment of our candidate. We are going to have a lot of critical thinking and appraisal with a lot of Q&A and evaluation and assessment, and we are gathering a panel of expertise. So we are trying to involve our fellows in the learning process to have a very high retention rate of the knowledge and the science in the pediatric nephrology, rather than just telling them or teaching them any knowledge. So involving them is probably going to have the best outcome. All of the scientific material during this fellowship program is released in very smart platform on a weekly basis, just to overcome the problem of different time zones, because we have students from 48 countries. Fellows have the freedom to navigate the educational contents and the scientific material throughout the whole week. Then they are going to submit the answers and the assignments and the tasks before the end of each week. And in this smart platform, we are following the fellows' engagement and performance on a weekly basis. If you haven't done yet, please go ahead and apply, because the application is going to close on December 15. Acceptance of notification, the letter are going to be sent on December 22nd. Next month, we should have induction meeting for RTA on Wednesday, December 18, 2025. We have Professor Elena from Amsterdam, our guest speaker. Then in January 15, we'll have an orientation meeting. Then we'll have onboarding webinar on Wednesday, January 29. The program again, the Pediatric Nephrology Fellowship Program, should start late January 2025. Upon completion of the program, you should receive an American accredited graduation certificates, and you should be an expert in the field, and you should be able to graduate to a trainer and mentor level in the pediatric nephrology field. We have a promo code 10 early for 10% discount. This will expire in the next 48 hours. So if you haven't done it yet, or if you want to share it with other fellows who are interested, please go ahead and use it. We are also giving full scholarship to low-income countries. So if you are one of these countries with a dark color, you can apply. Again, this full scholarship is not going to apply to lower middle or upper middle income countries. It just applies to the low income countries. So again, you can check on your country if it is low income country or not. And the great aim of education is not the knowledge itself, but the action. And we are aiming to improve our patient care and to offer them the best management and the successful outcome by teaching you to do that. And with that, I'm going to stop by here. And our next speaker will be Dr. Rasha Samir, and she is going to give us some examples about our fellowship materials, will give us some MCQs and clinical case scenarios. She is a associate professor of nephrology in Mansoura University. She is part of the World Kidney Academy Advisory Board. She worked personally with me for the last 3 years. She is one of the best collaborators and co-players that I have ever seen. And I'm very sure that we are going to learn a lot from her in the near future.
Thank you, Dr. Amr. Welcome, everybody. It's a pleasure to have you on board. I'm going to give a very brief summary of the educational materials that we'll have on our platform. And we believe that you're going to enjoy a journey of learning and building experiences and success throughout the World Kidney Academy Pediatric Nephrology Fellowship Program. So you're going to build your learning experience about case scenarios where you're going to test your problem-solving skills and be engaged in discussions, journal clubs to expand your knowledge every week with 1 to 2 state-of-art articles and multiple choice questions to test your knowledge. This will be done via easily accessible platform that you can use, access via your smartphones or laptops. And in brief, for the sake of time, I'm gonna give just a few examples of very simple materials that you may access through the educational platform. So for case scenarios, you will have a number of cases per week where you're going to read the clinical presentations, the laboratory workup details, and imaging studies, histopathological examination in different parts or serial parts for each case. So I choose to present one of these simple cases today. It's for a 16-year-old female presenting with rash and edema of lower extremities. The patient reports pains in knees, ankles, and intermittent abdominal pain. On physical examination, the blood pressure is 140/90. There is bilateral pedal edema. The patient has non-periodic rash located on both sides. On abdominal examination, there is no abnormality detected, no palpable organs, no masses, no tenderness. A urinalysis shows protein plus 2, 50% and to 60 erythrocyte per hyperfield and erythrocyte cast, and it appears light brown in color. So 16-year-old female patient, rash edema on the lower extremities. There is pains in knees, ankles, and intermittent abdominal pain, hypertension, pedal edema, and urinary abnormalities in the form of proteinuria, microscopic hematuria, and erythrocyte cast. So here you're gonna start the quiz and answer the questions. The first one, which one is following, is the most likely mechanism of the patient's hematuria? Mechanical erosion of the infected urothelial mucosa, medullary infarcts, vascular spasm, toxic disruption of the kidney tubules, or structural disruption of the integrity of the glomerular basement membrane. Please vote. Have you voted?
I think we got a combination of A's and E's.
So, the correct answer is structural disruption of the integrity of the glomerular basement membrane. This is because the patient's urinary finding was presentation of glomerular hematuria with light brown urine, erythrocyte cast, and albuminuria. So this most happened due to disruption of the glomerular filtration barrier, allowing red blood cells, albumin, large molecules to get filtered in the urine. So please go to the second question. Which one of the following conditions is the least likely to cause the patient's presentation? IgE vasculitis, lupus nephritis, kidney amyloidosis, cryoglobulinemia, post-streptococcal GM.
I think we have 37 with IgA nephropathy. We have 5% with lupus, 40% with kidney amyloidosis, 16% with cryo, 7% with post-streptococcal GM.
So thank you. The correct answer is kidney amyloidosis, because as we see, the patient here is presenting with a picture of nephritic syndrome, and this typically occurs due to disease caused by immune complex deposition, including post-infectious GN, cryoglobulinemia, lupus nephritis, IgA nephropathy, and IgA. Kidney amyloidosis is likely to present by nephrotic syndrome rather than nephritic syndrome or proteinuria. So now the patient have undergone these laboratory investigations. As we can see, hemoglobin is 12.9, white blood cells 8,400. There's near normal serum sodium, potassium, creatinine is 1.1, ENA, HCV antibody, hepatitis B surface antigen, and KBNC are all negative, rheumatoid factor negative, complement factors are in the normal range. So, based on these laboratory investigations, what do you think is the most likely diagnosis? Is the case of IgE vasculitis, lupus nephritis, Goodpasture syndrome, post-streptococcal GN, or microscopic polyangiitis? So, yes, the correct answer is IgE vasculitis, because the patient typically had clinical features of what we formerly called Henoch line purpura, including the joint pain, abdominal pain, rash, showing vasculitis, and IgE deposition in addition, and renal disease with nephritic syndrome, and normal complement levels with negative serology workup. All these with the possibility of IgE vasculitis, or what's formerly called Henoch line purpura. So, if the provisional diagnosis of IgE vasculitis is made, which of the following tests will confirm this diagnosis? Is it serum IgA level, high titer of circulating anti-IgA autoantibodies, 24 urinary protein, phase contrast microscopy, or no definitive test to diagnose IgE vasculitis? What do you think is the correct answer? Sure, there is no definitive test to diagnose IgE vasculitis among all these tests, simply because the diagnosis of IgE vasculitis for Henoch line purpura is based upon the presence of clinical manifestations that we just enumerated several times, with presence of palpable purpura affecting the limbs, with presence of one of the four characteristics: abdominal pain, arthritis, kidney involvement in the form of proteinuria, RPCs, cast, or hematuria, and proliferative GN, or evidence of leukocytoclastic vasculitis, as shown in the skin biopsy performed in this patient. So, which one of the following statement will be regarding IgE vasculitis would be correct? Is it an acute immunoglobulin A-mediated disorder that typically is self-limited? Or group E streptococcus has been found in cultures of greater than 90% of patients with IgE vasculitis? Is the disease more often severe and more likely to cause long-term kidney disease in children rather than adults? Is skin involvement rarely reported in patients with IgE vasculitis? The measurement of serum IgE is diagnostic for IgEV. What do you think is the correct answer? So, IgE vasculitis is acute immunoglobulin-mediated disorder that's typically self-limited. Skin involvement is even encountered in all cases of IgE vasculitis. And the presence of the majority of children present before the age of 10. And children generally have better prognosis compared to adults. Group E streptococcus has been found in cultures of greater than 30% to not 90%. And there are no definitive tests for diagnosis, as we just said. So based on the above mentioned data, a preliminary diagnosis of IgE vasculitis is made, and the patient is counseled that she may need steroid therapy. Which of the following does not represent an indication for steroid in patients with IgE vasculitis? Gastrointestinal hemorrhage, musculoskeletal involvement, severe skin lesions, persistent kidney disease, pulmonary involvement. In which case, steroids are not indicated. So as we can see all the choices, gastrointestinal hemorrhage, severe skin lesion, persistent kidney disease, and pulmonary involvement all represent severe manifestations of IgEV. Symptomatic and supportive treatment, yes, it is a foundation of treatment for patients with HSP or IgE vasculitis, but corticosteroids are indicated in patients with severe disease. So musculoskeletal involvement still can be managed with this symptomatic treatment. The last question in this case, if the patient presented 2 weeks later for follow-up, serum creatinine still 1.1, protein plus 2 urinary dipstick, her 24-hour urinary protein was 1.5 grams per day. Is the patient was counseled that kidney biopsy is required in diagnosis of IgEV? Which one of the following regarding the patient's initial management plan is correct? Dual RAS inhibition is typically indicated to improve GFR in patients with abnormal kidney function, or a 2-month course of corticosteroid should be directly initiated, or a combination therapy of CNI plus corticosteroid would be the best initial regimen in a patient with moderate IgEV, or just watchful waiting as long as the proteinuria is subnephrotic, or there is no clear consensus in immunosuppression in patients with non-severe IgEV. The patient has serum creatinine of 1.1, a hair 24 protein is 1.5, and the patient is counseled that kidney biopsy is required in this case. So this is the last question. And the correct answer is there is no clear consensus on immunosuppression in patient with non-severe IgEV. By this, you're gonna submit the quiz and find the score. So we'll just a sample of a case scenario. You're gonna find journal clubs where you will read one of the very state-of-art articles, up-to-date, evidence-based, and recently published. And then you're gonna evaluate your knowledge by multiple choice questions. So example, here's a very simple question about 6-year-old boy with Alport syndrome who's brought with his parents with communication challenges to inquire about potential hearing issues. So do you think which of the following is the correct answer? Is Alport syndrome may be picked up by neonatal hearing screening, or in males with Alport syndrome, hearing loss is usually undetectable by audiometry until adulthood? Or is it hearing loss in Alport syndrome initially targets high frequencies above the range of conversational speech? The hearing loss of Alport is contactive, or hearing loss in Alport syndrome is typically unilateral? Which of the following is the correct answer? As we know, the hearing loss in Alport syndrome, since in Europe, is bilateral, not unilateral, and it's usually diagnosed targeting high frequencies above the range of converged attenuated speech. So option C is a correct choice. So beside this, there will be a plenty of multiple choice questions to test your knowledge on live webinars where you're gonna stop and share experiences with experts field from all over the world. And today's webinar is an example. So set your calendar for a number of very informative activities and webinars. And I will stop by here and make you enjoy the most of this webinar. Thank you.
Thank you so much, Dr. Rasha. Very informative, and we'll see more and more of these questions. We have at least 900 questions during the fellowships, so this will be very educational and very informative. Now I will let Professor Ali to introduce our guest speaker, Professor Rukshana.
Thank you very much, Amr. It's an honor and my pleasure to introduce Dr. Rukshana Shroff. There are so many achievements. It would take at least an hour for us to introduce her, but to just in interest of time, I can briefly tell you that she's the professor and is at Great Ormond Street Hospital, London. Her main interest of work is what we are going to talk about and learn from her, treatment of chronic kidney disease and the bone mineral diseases and nutrition. And she has all the researches, multi-center researches. She's one of the co-editor of the 8th edition of Pediatric Nephrology textbook, and so on. So without further ado, I would let Dr. Rukshana to take over and teach us about the differences in pediatric dialysis.
Thank you very much, Dr. Ali. Thank you, Dr. Amr, for inviting me to do this. It's a real honor to join you all today. Let me just share my screen properly. Can you see this in presenter mode?
Yes.
Yes, very nice.
Perfect. Thank you very much. I will just have a pointer as well. Just 1 minute. Oh no, sorry. Sorry, that's the wrong thing. Okay. Right. Okay. So thank you again. So my topic for today is pediatric kidney replacement therapy. What's the difference from adult treatment? Here are my disclosures. Oh no. Sorry, what has happened? Here are my disclosures and declarations. So when I talk to adult nephrologists, the biggest, most senior, cleverest of them, they don't like looking after children. And children, of course, come in all shapes and sizes, in all kinds of moods, and some of them don't like adult doctors either. So we have to find a nice, happy medium, how we can manage the care of children, even when you're not a pediatric nephrologist. It's important that we think about this really carefully. There's an artificial cutoff age from pediatrics to adults. It can be 16 years in some centers, 18 or 21 years in others, and in some parts of the world, even as low as 5 years. Of course, we know transition is a really vulnerable period for young people to move into the adult world. And for young adults, the principles of management are closer to pediatrics than the geriatric care. We know that the average age of an adult patient on dialysis in Europe is now 73 years. So that is really the geriatric care. And so many aspects of care in young adults will be closer to pediatric practice. And finally, in many centers around the world, including in Europe and North America as well, adult nephrologists often have to look after children on dialysis. There are many commonalities and also some differences between the extremes of age. We know that the principles of HD and PD will of course be similar. dialysis access and fluid management and dialysis machines are similar. Infection risks can be similar as well. And then some outcomes in children and adults are also similar. So there are many aspects that we don't have to think of as two completely different worlds of management. There is a lot of commonality. So the principles of managing children, I think one of the most important things we have to keep in mind is that children have a lifetime of kidney replacement therapy ahead of them. And this is almost a mantra you have to keep in mind, because this means that children have to be managed differently in very many ways. And with this, we know that several aspects of the care have to be looked at differently. So some examples of this are preemptive kidney transplantation whenever possible, with the aim that we have to preserve dialysis access. This is PD and HD access, of course, and both. So preemptive transplantation for so many reasons is better. We also aim for home dialysis wherever possible, and this is again extremely important because it gives the child the freedom to go to school, play with their friends, and have as normal a time as possible. A holistic approach to care is very important. So, looking at the multiple comorbidities, especially with inherited kidney disorders, as well as also looking at the child as a whole and not just thinking of their kidneys. So, for example, the growth and nutrition of children is a crucial factor. And then finally, we have to manage the child within the family unit. And looking after and managing expectations of the whole family is extremely important. So in other words, this is person-centered care. There are specific aspects of pediatric dialysis that we can go through now. So starting with modality selection, dialysis access for PD and HD, looking at key aspects of the PD and the HD prescription, a little bit about preserving residual kidney function, and then non-dialytic management. As Professor Ali said, this is one of my favorite topics, so I can talk for hours and hours on this, but I don't want to bore you, and we've got half an hour. So I'm not going to tell you about how to do dialysis. I'm going to tell you the differences between children and adults. You will have seen this paper that came out about 2 years ago, 3 years ago, which is a consensus from several people around the world talking about prescribing peritoneal dialysis for high quality care in children. And this is really important because you note here the words high quality care. You do not see the word KT over V. So there's a movement away from simply measuring a number or a clearance value and focusing on a holistic goal of high quality care. So looking at this graph here, let's talk about dialysis modality selection. These data are from the ESPN ERA registry, and it looks at all children under 15 years of age who start, so incident KRT therapy. And you see there's almost an equal prevalence of PD and HD treatment, and about 20% of children receive a preemptive transplant. Actually, interestingly, when you look at the nephritic data from North America, you see sadly that this is not the case. We see that the prevalence of PD over the years has actually declined. The prevalence of HD has increased. And pretty soon now, because this data ends about a few years ago, sadly, HD is overtaking PD. And I really do think it's sad because in-center HD is not an ideal goal for young children. Next, if we look at modality selection, this statement is taken from the ISBD document that I showed you. And it says that in children, selection of the dialysis modality should be based upon the child's age, size, presence of comorbidities, family support available, and modality contraindications. But very importantly, the expertise of the team and the child and parent and caregiver's choice. And this factor about choice is very important because after all, it's not a person performing their own dialysis, it's the parent caring for them. So in addition to medical therapy, the family should be given the choice. And very importantly, like I told you, preserving dialysis access, both peritoneal and vascular, is one of the most important mantras of treatment. So PD or HD, what are the general rules? Home dialysis, so I'm not saying PD or HD, I'm saying home dialysis, whether it's is preferred to in-center hemodialysis. It gives the child time for school attendance and social activities. We need to avoid HD in infants where possible because of difficulties with vascular access. And unless there are contraindications to PD, such as, for example, a child with necrotizing enterocolitis, with gastroschisis, with absent abdominal wall muscles, there are really very, very few contraindications to PD. We must preserve the residual kidney function as best as possible, and usually, not always, but usually this is better preserved with PD than HD. And social difficulties can sometimes necessitate in-center HD. So I've already told you some of these things. The contraindications to the use of PD with absolute contraindications are abdominal wall defects, bladder exstrophy, a diaphragmatic hernia, and obliterated peritoneal cavity or peritoneal membrane failure. These are the only absolute contraindications. There are several relative contraindications, and I'll show you 1 or 2 slides on this. So access for PD in a baby is, of course, the catheter is very similar to what you use in adults. You will see here it's a double cuff. You see multiple end holes and you see the coil here. So very, very similar to what you use in adults. In neonates, of course, we need a much, much smaller catheter. And although it is similar in configuration, you see the exact measurements written here in centimeters, so that the surgeons, before they place the catheter in the baby, can actually mark the exit site, so that they hope to achieve the tip of the catheter deep in the pelvis. Now, this is sadly a common complication we see in children. Here you see the catheter is at surgery is completely, all the side holes of the catheter are completely occluded by omentum. So in this kind of situation, quite typically, the fluid can flow into the abdomen, but the return of fluid is obstructed, because when you get a pull on the to drain back fluid, the omentum blocks these openings. Now, the omentum in a child has a much larger relative surface area as compared to an adult. So the size or the surface area of the peritoneum is similar to our body surface area, which means, relatively speaking, it's greater in a younger child as compared to an adult. And therefore, where possible, our surgeons try to do total or partial or total omentectomy at the time of PD catheter insertion. Another thing that's quite unique in children is that many of them have gastrostomies, and gastrostomy feeding is something we do in the majority, as in more than 80 or even 90% of babies who are born with chronic kidney disease, or born with severe end-stage kidney disease, and definitely those who need dialysis in infancy. So gastrostomies have many, many benefits, and I wouldn't undermine this for a minute, but I want people to be aware that there's a greater risk of peritonitis, which is actually even 3-fold higher in children with a gastrostomy and who are on PD. However, please keep in mind that this is not, this is preventable, and that actually you can have, when a child is on PD already, the placement of a gastrostomy should be an open surgical gastrostomy, not a laparoscopically placed gastrostomy. And as long as you do an open surgical procedure, this is safe, because the surgeons will remove, literally pull out the stomach from the abdominal wall and then insert the gastrostomy, so that there's no spillage of gastric contents into the peritoneal cavity. I mentioned some relative contraindications for PD, and this is one of them. So you see here, this baby has a colostomy, and this colostomy, of course, is a dirty opening. So you want your PD catheter exit site to be as far away from the colostomy as possible. And obviously your stoma bag would come here. So you want your PD catheter as far away. So you can see a PD catheter is actually tunneled onto the central chest wall. And this figure here shows you that the catheter tip is deep in the pelvis as it should be. And then it has a long tunnel with the cuffs over here. This is clearly an unusual situation. We definitely don't do this in all kids. Usually the exit site is in the right or left flank, above the nappy line always, but this is an exception. And there is a mini case series we published of PD in children with colostomies. Now here is another situation we encounter. Sometimes children have abdominal wall defects. You can see this abdomen is scarred with multiple surgery. You see a drainage a drainage catheter here, and there's an incision here also for a potential PD catheter. Could you do PD in this child? Now, PD can be successfully performed in children who've had previous intra-abdominal surgery. There are nice case series with it. And when we encounter this kind of situation, we would counsel families to say, there is no proof that PD will work, but we have to give it a try. Okay, so let's move to hemodialysis. Which one of these would you choose? A central venous line or an arteriovenous fistula? We know from data that the access patency varies. So this is data from the International Pediatric Hemodialysis Network with almost 900 children over here. We can see the primary patency of an AV fistula in green is far superior to a central venous line in red or an AV arteriovenous graft in blue. And this is primary patency, of the fistula, of the access. And here is the secondary patency, again following the same pattern with AV fistulas being far superior to central venous lines. We know also that event-free survival is similarly greater for AV fistulas. Look at the picture of this little child. You can see, of course, from the photo that this person is very young. You see scars of multiple surgeries, and you see the dilated vessels on the anterior chest wall. You also, maybe with a little bit of eye of faith, can see a swelling here, which is the superior vena cava syndrome, and you see this dropsy here as well. What is even more important is this figure, this photo here of a venogram. So this child has had a bilateral venogram, and you see that there are multiple collaterals, but there's no blood going into the heart. So the superior vena cava, the subclavian, the brachiocephalic are all occluded. And this is a really horrible situation for such a young child who sadly will eventually die without access. Remember, if a young child already has occlusion of central vessels, then a fistula also cannot work, because fistula at the end of the day needs drainage into the heart through central vessels. So if you've lost your central access through multiple lines, infections, etc., then this poor person is set up to fail in adulthood as well, in older age as well. Okay, so this data is old data, but what it shows us here is the number of changes in kidney replacement therapy modality before reaching 18 years of age. So here you see the number of treatment changes. Those who have zero change means they've had a preemptive transplant, but you see that many patients have had 1, 2, and even 3 changes in access before they reach adulthood. And this means that patients go from PD to HD to back to HD PD and then transplant, sometimes fail transplant. So the bottom line from this table is we have to preserve vascular access. It's extremely important. We teach our patients and their parents, we give them these bracelets and we teach them, save your veins, save your life. So this is information that all families are taught. So blood in a young child who's with CKD, You should not use the vessels, the veins on their forearm as best as possible. So use the dorsum of the hand, not the antecubital fossa, to take blood or to put in any access, because this is the access the child will need in future. It will be their lifeline. Another very important thing for children is the maturation of AV fistulas. And we know that AV fistulas can take longer to mature in a younger child as compared to an older person, an adult. And so we advise that the access should not be needled for the first 30 days. Ideally, wait for about 6 weeks for access maturation. In our center, we do arteriovenous fistulas even in children as young as 10 kilos and even 8 kilos sometimes, but definitely by 10 kilos. And the smaller the vessels, the longer it can take for access to mature. So be careful. Don't start putting in needles until you have an ultrasound and you confirm good flows. And it takes at least 30 days, if not 6 weeks or longer, to achieve this. Okay. So we've discussed access for PD and HD. Now just let's look at a few unique aspects of the PD prescription. So unique for children, of course. Now children will have a higher intraperitoneal pressure, and with that there's a risk of leaks and hernias. Children are often fast transporters. And then, of course, the concept of preserving the peritoneal membrane. So let's look at these three concepts. So first of all, intraperitoneal pressure may be higher in children. So in this study here, you see intraperitoneal pressure being measured with a manometer in this baby. And there's a direct correlation between the intraperitoneal pressure rising, especially with a higher body mass index. A high IPP can increase the risk of enteric peritonitis as well. Now, I have to admit that in my center, we do not measure the IPP. And we feel that going by guidelines for the total fill volume in children, which is adjusted per meter squared body surface area, we don't need to have these guidelines, and we don't need to measure the IPP every time. Another thing is children are typically high or fast transporters. You know, this is done from a PET test, and a PET test tells you about the peritoneal membrane performance in a sense. So children typically will be high or high average transporters. The younger the child, the much greater likelihood that they're high transporters. Older children and adults, so teenagers and adults, are often low average or low transporters. Now, you know that when a person is a high transporter or a fast transporter, there is reduced ultrafiltration because they absorb that glucose very quickly. There's a loss of proteins into the peritoneum, and with that also a loss of sodium. So with this in mind, one has to adjust the dialysis prescription. So we often do CCPD, so frequent exchanges, and shorter cycles and exchanges. And CAPD can be used, but it's used usually in older teenage children unless a person is polyuric. Another thing is because of loss of protein in the peritoneal fluid, we increase the dietary protein intake, often going as high as 4 grams per kilo per day stepwise. A third thing is there's loss of sodium, and this is especially important in the younger children and the babies. So sodium supplements may be needed. Now, this sounds very controversial almost, or contradictory actually, sorry, to give a person on dialysis sodium, but it's not unusual that children might need sodium because of the high sodium loss into the PD fluid. And finally, icodextrin, which of course has a long and slow removal of fluid by convection, is very helpful to remove sodium as well. We know from multiple studies looking at peritoneal biopsies that biocompatible PD fluid is likely to reduce the damage to the peritoneum. It preserves the peritoneal membrane and therefore, of course, preserves kidney function for longer. Now, looking at the HD prescription, there are unique aspects for children as well. So we need to be careful that we select the appropriate dialyzer size, which matches the body surface area. You can be maximum plus 10% more than the body surface area for dialyzer size, but not much more than that, because the extracorporeal volume will then be higher. And an extracorporeal volume should be no more than 8 to 10% of the child's total blood volume. Blood volume monitoring, or the crit line as it's called, is not available in the young children under 40 kilos. And this is quite a hindrance, really, quite a drawback for our monitoring. And then HD machines need to have good UF accuracy of plus or minus 50 mils per hour. And otherwise, you can cause catastrophic hypovolemia, especially in young children. Many dialysis machines will tell you that the UF accuracy is even within a range of 100 mils an hour. Now imagine in a 50 mils per hour, that means in 4 hours, 200 mils of fluid. You can either gain or lose 200 mils of fluid, right, in 4 hours. In an adult, it's inconsequential. In a baby, this would be huge, and it can actually cause extreme intravascular depletion or excess fluid overload. We know that to improve dialysis outcomes, we can perform hemodiafiltration in children. And from some of these studies, we've seen that hemodiafiltration will actually preserve the carotid intima media thickness without causing any increase over a 1-year follow-up. Whereas in HD patients, this increases very dramatically. And part of the reason, not the whole reason, but part of the reason for preserving carotid IMT is that the blood pressure is far better controlled in HDF than in patients on HD. I know that colleagues from pediatric nephrology, colleagues from Egypt, have done some very good studies as well, looking at left ventricular function and diastolic function and dysfunction, and shown that HDF preserves cardiac function in children. We've also seen that there's improved growth with HDF compared to HD. And a reason for this is improved bone health, with the bone osteoblastic function with BAP being far superior to osteoclastic function in HDF patients. Another important thing to recognize is technical limitations with dialysis. We published this in Kidney International to try and raise awareness for the global community and for the caregivers that actually, sorry, this is in the middle, actually across many different countries and in these different age ranges. For example, on children under 10 kilos, there is no approved dialysis machine. Of course, we have to do dialysis, but we are using machines that are not validated, not approved for young children. And this actually is even up to 10 to 15 kilos. And only in the older children do we have machines, dedicated machines for dialysis. So with so many issues with dialysis, how can we attenuate CKD progression? So just a few slides to look at this. So attenuating CKD progression has been described very nicely by this new guideline in 2024 on clinical practice recommendations for adults and children with CKD. We see that there's a distinct age trajectory going from the fetus or to adolescence and of course beyond. The risk factors for GF that affect GFR vary at different ages, with many things including drugs and pharmaceutical agents, but very importantly, the genetics, the family history, intrauterine growth retardation that can impair this. And then of course the factors that we can manage across the ages to preserve residual kidney function. Sorry, I need to go forward. The same guideline has put together these 12 points to look at preserving kidney function over the years. The next thing to look at is an important difference between children and adults is in their bones. And if you look at this graph here that goes from birth to 100 years, and the skeletal calcium mass is on the y-axis. At birth, there's only 25 grams of calcium in the skeleton, and this has to increase to 1.5 kilograms in an adult male. So you need to accrue a huge amount of calcium, especially in the early years, in the early phase of growth, to be able to completely and fully mineralize your bones. This means that if there's even a 10% loss in peak bone mass in this amount, is a 50% increased risk of fracture after menopause. Now, the same way that healthy people need calcium, our CKD patients also need calcium. And we know that the calcium balance is positive, especially in infancy and also in young adults, in order to achieve this level. Clearly, in adult practice, in older people, when there's a calcium loss from the skeleton, this is a different situation altogether, and therefore the management of mineral bone disease is very different. Also, from this graph, you can see that the children need a very high amount of calcium in the infancy and adolescent phase, and therefore this need for high calcium often means we use high calcium dialysate in infants, and sometimes also in the crash landers, so those with hungry bone disease with untreated CKD. We published this document along with the adult nephrologist on a consensus statement in adults and children with chronic kidney disease. And we see here that the recommendations for adults and children vary, and this is important to keep in mind. Finally, we also know that too much calcium is bad. It's associated with vascular calcification, and vascular calcification is the most common cause of death in children, as well, even in young children and adults on dialysis. Last concept to keep in mind is the Brenner hypothesis. Now, all of us learned this in medical school, and basically it means that a small baby with small kidneys, that means few nephrons, is at a higher risk of maintaining their blood pressure, handling sodium, and a high risk of hypertension and kidney disease in later life. We see from this figure here how the blood pressure varies in response to a sodium intake. So you can see a high sodium intake here. If somebody increases their sodium intake along this kind of trajectory, a good healthy pair of kidneys will show a small increase in blood pressure. A person with a single kidney will have a much higher increase in blood pressure in response to sodium. And a person with a nephrectomy or a small reduced renal mass, in other words, will have a very dramatic increase in blood pressure with a sodium load. So this is just one snapshot of showing how important it is to keep in mind that single kidneys and patients who have a reduced kidney mass will be affected by a sodium load. There's a graded risk for CKD with prematurity, as you see here. So very premature, extremely premature babies under 34 weeks in this blue or purple line have a much higher risk of going into CKD as opposed to those with better preserved with term deliveries. And in fact, there's a threefold higher risk in preterm and small for gestational age children, and if there are associated congenital abnormalities, a 20-fold higher risk. This figure with this paper which came out recently also shows the long-term outcomes following childhood dialysis. Now, this is children who have acute kidney injury, but as you see here, we don't see it, sorry. As you should see here, there is a much higher risk hazard ratio for, as you see here, for de novo kidney disease and for de novo hypertension in somebody who's had AKI as an infant. And finally, optimal dialysis goes well beyond KT over V, looking at all of these different aspects that must be kept in mind. And the goals of our treatment from the SONG HD initiative is really what our children want. They want life participation, survival, good kidney function, but basically they want life participation, which really means they want to be normal, like their friends. So in pediatrics, we have a holistic family-centered approach to dialysis. You have your little patient, and with them comes a mummy. But very often, we have lots of well-meaning aunties who want to influence and tell you what to do. So it's a lot of responsibility to manage the parents well, and to keep these aunties a little bit out of the picture sometimes, because their idea of a healthy diet or healthy care may be very different from what a CKD patient needs. So parents, as the child's advocate, the ethical issues of dialysis are very, very important to consider. And remember that about 30% of children who need dialysis from birth will have associated comorbidities and genetic disorders. So here, trying to keep play specialists, keeping the children entertained, explaining dialysis in their own terms is extremely important. Another crucial thing is a plea for research. Children do differ from adults in so many aspects, from their physiology, growth, and communication needs. And the patient and the child must be considered together. We currently have very low quality evidence for most of our guidelines, and quality improvement projects in dialysis and enhancing literacy is very, very important. So, in a summary, as we go from the fetus and infant to an older age, the goals of treatment are optimal dialysis to promote maximal life participation, preserving access, peritoneal and vascular, and keeping in mind the differences between children and adults and how best we manage this. Thank you all very much. One last slide is a little bit of free advertising to tell you about our Advances in Pediatric Dialysis course. This is going to be held in January 2025. This is 2 half-day webinars, and we try and keep it free for all delegates from low and middle income countries. Please do register, and we hope that it'll help you with further dialysis advice. Thank you very much. I will stop sharing now.
Thank you very much. Thank you very much, Rukshana, for real wonderful and terrific talk. And in very short time, you just go over all things, most of the thing in PD and HD, and what I can say, holistical approach in managing child, 360 degrees, not just only looking for KT over V, and just looks to every part of the child. So before go to talk, so I need to just tell our colleagues, attendees, just write your please a question in Q&A, and we try to answer most of the questions. So before we start from the attendees question, probably I would like to ask one questions. For the, something you mentioned it, which is said that in North America start to have HD more than PD, which is really very sad for pediatric nephrologists. You know, as we know, PD is very child-friendly, that he can attend the schools and he can play most of the day rather than he's been connected to the machine 3 to 4 times a week. My question in PD, how you will look at for adequacy of the peritoneal dialysis, looking to the very old studies of Canosa studies and Adamex studies in terms of adequacy of peritoneal dialysis, especially in the small kids.
Yeah, and that's a very important question. So the older studies looked at, as you have mentioned, Canosa, the Adamex studies looked at KT over V, and they saw that actually there was, by increasing the dialysis flux, going from low to high flux, or by increasing the flows, the high to low, low flux to high flow, low flow to high flow, there was no improvement in survival. Now, remember, KT over V is measuring urea, right? So urea is a low molecular weight toxin. It is very, very easily cleared by diffusion. So it is not a big deal to achieve a higher KT over V and higher diffusive clearance. More and more so, the focus is on convective clearance. And we know that convection is what comes either on PD with ipodextrin use or on hemo with HDF. And convective clearance achieves far better removal than diffusive clearance. So focusing on a number is not a good idea. We try and move patients away from this number focus.
Thank you very much. I would like to mention that me and my close friends, Sidharth, we are together moderating this session. So probably I will just introduce the initial question, and I will leave the mics with my my colleague. So there is one question now here from Ahmed Al-Sabi from Saudi Arabia. He's asking, is the PD an absolute contraindication in case of brown belly syndrome?
Is PD a contra? No, no. So prune belly syndrome, you can do PD. You have, and we do have some patients on PD with prune belly. It's very important though to keep in mind that you have to be careful with your fill volume. And a higher fill volume can cause hernias, because these children have these muscular defects. So yes, PD can be done, but cautiously without excessive increase in the fill volume. A good thing with these in a perverse way, a good thing with these children with prune belly is that most of them have PU valves and they're polyuric. And because they're polyuric, you can get away with smaller fills and you don't have to stress about fluid removal.
Okay, there is another question from Muhammad Matoudi. He said that what is the absolute contraindication for insertion of the BD catheter, Bermath, in HD patient? There is any absolute contraindication?
For a PD catheter, you said?
Bermacath, Bermacath.
For a permacath, sorry, I didn't hear you. For a permacath insertion, there are almost no absolute contraindications. I think if a patient has vascular stenosis or something like that, then it's a difficult thing. But then you have to put the catheter in some other, including infracardiac in the femorals if necessary. But there's no absolute contraindication to hemodialysis, no.
Excellent. There is another question. Let me see from different attendee. Yeah, that's another simple question from Muhammad. He said how to choose the dialyzer surface area in young children.
So the dialyzer surface area has to match the body surface area as closely as possible. So we would first calculate the child's body surface area and then look at a dialyzer size that is as close to the body surface area. Another thing you need to do is to look at the volume of the dialyzer and the volume of the lines that you use. So the total dialyzer plus line volume is what the extracorporeal circuit will become. And the extracorporeal circuit should be no more than 8 to 10% at the most of the total blood volume of the child. So these calculations are important. In the very, very young children, you might have to prime the dialysis circuit with blood or with albumin to prevent a large extravascular volume of blood going out of the child.
Another question from Naresh Kumar from Chennai. He said, what is your experience on CABD in infantile age group, where he personally find it is difficult as child is not cooperative and parents find it is very tough, and recurrent peritonitis due to unsterile handling from child himself?
I think this is a very important point, no doubt. There are other reasons why CAPD is not ideal. So Dr. Kumar has already listed some of them. Other reasons are that the younger child is a high transporter, and a patient who's a high transporter will not do well with intermittent CAPD exchanges. They need rapid exchanging on a cycler dialyzer. Now, I understand in many parts of the world, a cycler, as in a PD machine, may not be available, and you might need to manually do multiple frequent cycles of dialysis, and that is important. If your child is persistently trying to pull out a PD catheter, you need to also think, why are they so distressed? I wouldn't start with an assumption that it's bad behavior. I would start with an assumption that this catheter is somehow irritating the child, and quite often you can have uremic pruritus without adequate dialysis, and you can of course then get reactions to the dressing around the dialyzer as well. So to keep those points in mind, we have many young children on PD, and unless they have extreme itching, they don't really try and pull out catheters as such.
Totally agree with you. Also, for sometimes we have Rukshana patient renal failure and still he's polyuric, especially small kids with polyuria. We find a little bit difficulty in doing peritoneal dialysis on this type of patients.
You're
So
right.
what is your advice on those?
And indeed, it's difficult. You're right, Khalid. So what we have to do is in these cases, you have to accept that your PD is for clearance and not for fluid removal. That means you switch off all the alarms on your dialysis machine, allow them to absorb some fluid if necessary, and don't worry about it. If they absorb fluid, because usually they will just pass it out in urine, and you will not be and it will not affect the fluid volume of the patient, the blood pressure of the patient. Another very important thing is when they absorb fluid, when they're polyuric, you might need to give them salt supplements, and this is really important in the youngest children.
Very nice, very nice, very fruitful discussion.
Dear Dr. Sadat, maybe he will. I will hand the mics to him. So Sadat.
Thank you, Khalid. Excellent talk, Dr. Rukshana. Since we are running behind time, Dr. Rukshana, could you type answers? We have a lot of questions in the Q&A. So
Yes, sure.
would you be able to type those answers for the delegates?
Sure, I will do my best. Sure.
Thank you. Thank you, Dr. Rukshana.
Thank you very much. Thank you.
Very nice. Thank you
Thank
so
you
much.
very much, Rukshana.
Thank you.
Thanks, Khalid.
Thank you.
Thanks, Sidharth, and terrific presentation as usual, Rukshana. Now we have a very brief, challenging case. Professor Hanan Saad, she's a professor of pediatric nephrology from Cairo University. Currently, she is working in Saudi Arabia. She's going to walk us through very challenging, complicated cases of CKD stage 5 before starting dialysis.
It's my honor to be here in this webinar with all elegant speaker and all special attendees. I would start my presentation. Here we have 4-year-old girl with CKD due to multicystic dysplastic kidney on one side, and the other side show hydronephrosis and hypoplastic also. She was on conservative management, but unfortunately she progressed to stage 5 CKD. She has severe bone mineral disease with bone deformity, refractory hyperparathyroidism that necessitated subtotal parathyroidectomy. Post-operative, she was kept on supplementation, calcium, phosphorus, and other management medication for CKD. Her past medical history is positive regarding in-ICU admission as she was preterm, and also admission due to repeated admission due to osteomyelitis. The parent was counseled regarding peritoneal dialysis as she has severe hypocalcemia and fragility fractures. I know you are short running in time. How frequent you seek acute as a case of end-stage kidney disease? If you can write in the chat box. By examination, the patient has failure to thrive, weight and height below 5th centile with frontal posing and severe bone deformity with bowing of the arms and leg. She is on gastrostomy tube feeding with cast due to left femur pathological fracture. Here is the gross curve. It's away from the normal. And here is her labs show impaired kidney function, low hypocalcemia, hypophosphatemia, very high alkaline phosphatase, and anemia. Her imaging study show the ultrasound show multicystic dysplastic kidney on the right side, and the left is small with moderate hydronephrosis. X-ray show generalized decrease in bone density. I will explain the X-ray later. VCUG show no vascular reflux, and DTPA show non-functioning right kidney and severely impairment of the left kidney function without obstruction. Here is the current medication for the patient. She is supplementation with calcium, phosphorus, active form alpha-calcidol, and anemia with dartoprotein, folic acid, and iron. Could you please see this X-ray for the patient? Here, if you can see, this is X-ray femur and tibia and fibula. You see here the decreased bone density, the angulation in the tibia and fibula, the exaggerated growth plate, and this is bony island, which is brown tumor. Here is maybe more evident or more prominent. There is the refaction. What is called here is flask-shaped deformity with widening of the metaphysis of the bone due to severe osteomalacia. And also here is a cupping, fraying of the bone, tibia and fibula. If you can write also in chat box, what is your comment on this head of the femurs, both head of the femurs? This show incomplete ossification, delayed ossification, which is characteristic of the osteomalacia in patient with CKD and renal impairment. Here is the prominent cross plate. It should not be clear like this. This head looks like a vascular necrosis with the rarefaction, abnormal configuration of the head. Here is, as we said before, the crown tumor, and here is subperiosteal reaction. So our question, when to initiate dialysis for a child, BD or hemodialysis or transplantation, CKD, MBD in pediatric. This was clearly shown in Professor Rukshana's lecture. And also here the message is early correction of complication, especially CKD, MBD, early dialysis for better transplantation outcome.
Thank you so much, Professor Hanan. I think as a healthcare provider, we should be all guilty to see this very severe refractory renal acidostrophy with this child. Was, I would call him a jelly child. Doesn't have skeleton, doesn't have bone. It's actually soft tissue rather than bone. If you look to the X-rays, you'll see the soft tissue is whiter than the bone. It's more dense than the bone. The bone is very weak. The skeleton is unhealthy. And of course, the consequences, if you put the patient on PD, HD, kidney transplantation, survival of these kind of patients are very, very short. Complication is very, very bad for this patient. And I think early diagnosis, early identification would be the key. It's too late. Of course, we can do our best to prevent long and short-term complication, but it's already too late. Sometimes we think doing parathyroidectomy might resolve the bone issue. This is, in the vast majority of cases, it's not going to be curative. And the spectrum of the patient just is going to change from high turnover bone disease to low turnover bone disease or adynamic bone disease. Of course, this patient looks like have severe degree of osteomalacia. We don't see this in adults, but we see more in kids because of severe hypocalcemia, severe hypovitaminosis D, hypophosphatemia, especially after parathyroidectomy. I saw these cases in adults in patients with aluminum toxicity or iron overload. Very rare to see it in adults, but I think Dr. Rukshana, she see it more than me in pediatrics. So this patient was very soft bone, severe adynamic bone disease, osteomalacia, is going to fracture and refracture. So the take-home message, I think this patient should have started dialysis for, since ages. Improvement and optimal correction of his CKD MBD parameter would be the key. Early identification of his disease, because when the hyperparathyroidism, it changes from a polyclonal to a monoclonal, proliferation of the cells. With severe downregulation of vitamin D receptor and calcium sensing receptor. It's very late to control it medically. And most of the time when you do surgical management, you just take most of the tissues out and you end up by having PTH in 2 digits range with, hypoparathyroidism. Do you agree with this, Professor Rukshana?
Yes, definitely. Absolutely. That's an excellent summary. And as you say, it's a much greater risk in children than in an adult whose skeleton is already mineralized for sure. Yeah.
Thank you. I would also add that several studies have shown that when you end up by having severe adynamic bone disease, you also end up by having severe cardiovascular calcification, as Dr. Rukshana mentioned, It's one of the leading cause or the most common cause of our patients' mortality. So what happened is you are giving a lot of vitamin D, calcium, phosphorus. If you don't have PTH, the calcium and phosphorus is not going to stay in the bone. And where does it go? It goes mainly to the soft tissue and calcify the soft tissue. If you don't have PTH, you don't expect the calcium to be normalized, because the extracellular calcium concentration, the main determinant of this is the PTH. So if you don't have PTH, or the PTH is very low, and if the bone is very adynamic, which usually takes about 99% of the calcium and about 85% of the phosphorus. So if you don't have that, it's going to stay outside the skeleton. And when we do extracellular calcium concentration assessment, we don't see hypercalcemia. So this should go somewhere else, and mostly it goes to the cardiovascular system and induce severe cardiovascular calcification. Do you have any further comment, Dr. Rukshana? Because we are a little bit late, so I'm sorry for that.
No, don't worry. No problem. I was just going to say CKD-MBD is one of my favorite topics. If you ever want me to talk on that, I'll be happy to.
We should do another session with the CKD-MBD in adults and in pediatrics.
That would be very interesting to do both side by side. Yes.
Right. Thank you so much. I will let Dr. Ali summarize and do closing remarks for this fantastic webinar. Thank you again, Professor Rukshana, for the amazing presentation. Thank you so much, Professor Hanan, for this challenging case.
Thank you very much, everyone. I'm impressed by the participants' enthusiasm, and it only shows that how good this webinar has been, despite we've exceeded our time limit. There are more than 100 participants. They've always remained, and we hope that you have learned a lot from, like myself, you've learned a lot from this webinar, and we hope to see you all soon with our fellowships and other academic programs. Thank you.
Thank you so much, Dr. Ali. And if you have, for the attendees, if you have any further questions, or if we didn't address your question, I'm very sure with Dr. Rukshana's generosity, she'll be helping answering your questions. We'll see you again in the fellowship. We'll see you in our next month webinar. Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.